Dr. Gauthier, thank you so much for being here today to share your knowledge. Please go ahead.
Thank you, Diane, and good morning, everyone. Thank you for being here. I'm honored to be the first of 5 or 6 presenters from McGill to go over the broad topic of neurocognitive disorders. The next slide, please, Diane. So the content of my presentation, it's going to be from a clinician perspective and to help you prepare to have a doctor's visit if you go with someone, especially a neurologist, for the first time. We're going to use a well-accepted template, sort of a drawing of the natural evolution of symptoms over 8 to 10 years when you have what we call a neurocognitive, that is something happening in your brain that affects memory, language, and other abilities. I will introduce to you some terms that you could follow up on later in your reading. Some of them are of interest because in a way it does affect everyone as we get older. Like, I forgot my keys, that's something terrible. No, but if you forget what the key is for, that's something more important. So I'll have a few hints here and there as we go along, and we can, if you wish, follow that up in the question period. So symptoms and then clinical assessment. What do we do at the doctor's office, whether it's a family doctor or a specialist? What kind of tests do we do when it's someone with a memory complaint or having difficulty with words that are progressing, not a stroke, one-time acute thing, but rather it's slowly progressive? How do we tell someone and their family that they may have a condition such as Alzheimer or a related disorder? And the early stage of management. And other lectures to follow by Dr. Gélina will probe more deeply into day-to-day changes if you have these conditions and how you adapt. And Dr. José Moret will go into somewhat preventive modes and how to treat things that occur other than neurocognitive things, like you also have decreased hearing as you get older, you walk a bit more slowly, etc. And then there'll be Dr. Vitali at a date still to be confirmed, who's a specialist in progressive aphasia and stroke management. So let's move on. Please, Diane. So we're going to use this template for the next 5 or 8 minutes. So I'll walk you through it. As you get older, over 65, practically speaking, there may be a phase of mood changes, which now has a name. We're going to get into that. Then there is some decline of your speed of thinking and how do you make a decision about things in daily life. And then it could progress to something more significant, like you forgot really something important that you used to do. And so there's an impact on daily life. And then there's, at least for Alzheimer, a second phase of behavior changes, which are quite troublesome, sometimes at home, like you don't know anymore where you are and who your spouse is. And it can lead to agitation, restlessness, and notice that this improves with time. And then motricity, it's a Parkinson-like late stage of Alzheimer, where you have muscle stiffness and you have trouble walking and you have trouble swallowing. So this is just the overview. Now we're going to go more slowly at each step. Notice that even if you have symptoms at a certain stage, it doesn't mean you're going to progress all the way through. You may have resilience factors in your brain that will prevent progression. So this is a classic example of someone who is doing well. She's multitasking. Notice she's on the phone and she's doing her emails, and she made a cup of tea, and so she's fine. Next slide. That person, okay, oops, she forgot her password at the bank. And she probably is like me. She's going to write it down now in case we forget the password. But she knows how to use the machine and she knows how to pay her bills. But she may be a bit upset about that forgetfulness, that lapse. So next slide, please. So for now, we're calling this stage of aging subjective cognitive decline. Subjective means it's only you who worries. It's not the person who you live with. It's not your children. It's only you. You're aware that you're not as fast as you used to be 5 years ago, 10 years ago. And it's cognitive. So oh, I forgot where my key is, but thinking back, okay, what did I do last time I came in the house and so on? And it's decline. It's not impairment. So these are very important words, and we've been struggling with those words for the past 10 years. So now it's what we call it, subjective cognitive decline, and that's universal. So if you try to learn a third language, it's going to be an extra effort. And believe me, because I'm trying to learn German because of my 3 German grandchildren. It's not as easy as it was when I was 20 or 30 to learn a second language. So that's normal. Next slide. But you may be upset by these changes because you used to be fast and you used to play bridge so well, and now you have to pay more attention. So there may be something called mild behavioral impairment because you're upset that you're not as fast, and maybe the family's starting to sort of suggest maybe we can help you with this so you're faster or whatever. So there may be apathy, sort of social withdrawal, emotional dysregulation. So you're a bit upset, you're more cranky, or you may be a bit restless when you worry about things. You may be a bit abrupt with the grandchildren because they make too much noise, or you may think your partner is actually cheating on you. I mean, this is extreme, of course. But so these are subtle things that you can actually look for on a checklist. Next slide. So this is a homework that you may want to do. It's called Minimal Behavioral Impairment Checklist. It was designed by a young psychiatrist in Calgary, Dr. Zaina Ismail, and he kindly gave the world this checklist, which you can get online, MBI, and just put MBI in Google and you'll have the checklist. Just a note of caution, everybody has something in there. And to be meaningful, it has to be at least 6 months duration that you have a symptom that is new. So if you were always a bit cranky and you're just a little more cranky, that doesn't count. But if you were easy with people, at ease with people, and then there's a change, it may be more meaningful. It doesn't mean Alzheimer, not at all. It could mean you're depressed, you're socially isolated. It could mean you had a small stroke. It means go see your family doctor and get a good checkup. But it's a fun thing to do, and you can do it yourself, or your spouse can do it, or the doctor or the nurse can do it. But it was designed to be completed by the individual who has some concern. Next slide. Okay, so now we call it mild behavioral impairment. Notice that it's before dementia. And we're at McGill studying this phenomenon with scans of the brain to see if these changes correlate to some degree with some amyloid, tau, or other protein buildup in the brain. And it's too early to really state that if you have some of these symptoms, at least 6 months, it means you're at higher risk of whatever. It's too early to say. But it's one of the things that we now measure in memory clinics or brain health clinics, as we're switching to this concept now, brain health clinics and geriatric assessment clinics. Next, please. Now, next slide, please, Diane. Okay, so something is happening now to that lady. She's forgetting things, and it's starting to be noticeable by the family, especially her daughter. It could be anything. She forgot to pick up the grandchildren at school, which she usually does, or she had trouble with the car because it went, there was a detour, and she just couldn't understand the instruction. It could be lots of things that are not major in her life, but it's enough that somebody's concerned. So next step, next slide, you go see your doctor, and the doctor will do the MOCA. It's called the Montreal Cognitive Assessment, MOCA. You can actually look it up also on the web. It was designed by a young neurologist from the South Shore, Dr. Nesradine, and it's used worldwide. It's been translated in every language. There's 3 Chinese versions. The thing is, if you practice online, it won't be as reliable when we test you. But guess what? We have version 2, version 3. So it's okay if you practice once. But it's very well designed to pick up subtle change in your ability to think, your speed of thinking to some degree, remembering 5 words with a distraction, and what were the words, and then the date and the usual things. So that's a scored out of 30. If you have at least a grade 8 education, you should get 27, 28, 29, 30 at any age. If you score less than 26 with that level of schooling, it will be noted, and we may repeat the test in a year to see if it got better because you fixed whatever was happening in your life. Maybe you were a little depressed, maybe you were taking the wrong pills, it was clouding your memory, whatever. But if it declines another 2 points over a year, that could be meaningful. So all this to say that there are tests like this that are well-designed, multiple languages, but they were designed for people with schooling of in the order of grade 7. So they don't work well in people who are analphabet. They don't work as well with people who are aphasic. So that's a specific thing you can ask Dr. Vitali. What do you do with someone who has a lot of problem understanding language or expressing themselves? We have other tests instead of this one. Okay, that's the MOCA. Next, so if that person has a score that's below what you expect for age and education, we will call that person mild cognitive impairment, but it's not dementia. And if you look at the world, the experience shows that only half of the people with this symptoms and an impairment on a paper and pencil test like the MOCA, only half of them actually progress to dementia or something similar. Half will be stable or actually improve, because the mild cognitive impairment could be reversible if it's due in great part to decreased hearing, decreased vision, taking the wrong medicines, etc. I'll get into that when we do the clinical assessment. Okay, next slide, please, Diane. So now this lady, she needs more help. She's having trouble paying the bills, and it's not just a password anymore. It's actually, did I pay the bills? Or maybe she paid some bills twice. So this is getting to be significant impairment of daily life. She probably also has trouble keeping track of her pills. Dr. Gelina will go into that in detail with you very soon. So she needs help now from someone for at least some aspects of daily life. So we're crossed the threshold here. The cognitive impairment has interfered with daily life in a significant way. So now it's called major neurocognitive disorder, or the other term is dementia. So this is the definition: a decline in intellectual abilities. Usually it's memory plus something else, like memory and ability to make decisions, memory and finding your way around with your car in the city, memory and recognizing people, just looking at them, or memory and looking for words. There are atypical presentations such as progressive aphasia, memory is still fine, or progressive visual impairment, memory is still fine. So there are variations. It does interfere with daily life, and that's individual. Could be very different from a man and woman, and you're still working or you're retired, etc. Unfortunately for Alzheimer, there's something special. People are not aware as much of what's happening. It's called anosognosia, or they may be aware of it, but they deny there's a problem and they don't want to see the doctor. So some families have to juggle with the issue of actually going to see the doctor and getting a checkup. Of course, when you're still aware of what's happening, at least in part, it causes anxiety and maybe some depression. And there may be an overlap of mild dementia and depression. Next, please. Now, this is now a mild dementia stage, or major neurocognitive disorder early stage. And you see the line now in red. We have impairment of activities of daily living and some decline in cognition. The mood may have improved because you're not aware so much anymore what's happening. You just may be a little socially withdrawn. It's called apathy. And you're not yet in the big behavior disturbance phase. So it's a kind of quiet time when you have help at home, which could be part-time. You can still be home with some precautions, etc. Next one. Now there's progression over maybe 3-5 years. It varies between people. Now you need help to choose the clothes, to put them on, etc. Again, Dr. Gelina will go over that with you carefully. So, but you need someone not quite living in, but close. Or you may actually have to relocate if there's a safety issue. So you're moving into the moderate stage. Next slide, please. So moderate stage, you're losing more autonomy. It's now interfering with basic things like choosing your clothes, putting them on, using the bathroom, the kitchen safely. And then you may have a bit of not recognizing the people, the house. In our culture, this means usually you move to another environment, long-term care facility, or you need additional help at home. And then the last stage, next one, please. It's more motoric. So it's Parkinson-like. You have trouble walking, you could fall, and you have eventually difficulty swallowing. Next one, please. So that's the severe stage, which is common to all kinds of dementias. It's Parkinson-like. What would be atypical in when you see someone or you follow someone over time is that the Parkinson-like changes, if it's too soon, you suspect some specific causes. I'll go over that with you in a second. If you have behavior changes that are very early, like visual hallucinations, that could give you a hint. It's not Alzheimer. So this pattern I just showed you is typical Alzheimer pattern. And now I will go into how as clinicians, with your help, we can go through the differential diagnosis. So when you go see the doctor, whether it's a family doctor or a specialist, the history is the key. So please write down the history over time, the first symptoms you noticed, how it's changed over time. If you tried a medicine, write down the name. If you had a side effect, also write the name, because it's important to know. Physical exam is really to look at general health. And the neurologic exam is mostly to look for asymmetry. So with our hammer, we check to see if you have excessive reflexes on one side versus the other, which would suggest perhaps a stroke or a tumor or something affecting one side of the brain. The MoCA we already talked about. The other test that's done at nearly every visit in every clinic is the MMSE, mini mental state examination, or Folstein. Dr. Folstein is the doctor who created that test. They're often done together also. And then complementary tests, now that I will go over, because you may be interested to know what we do in terms of scans of the brain. And they're all available in Laval and Quebec. It's all covered by Medicare. Next slide, please, Dan. So everybody gets blood work. It's the same blood work as you would normally get once a year if you are using preventive medicine approach. So you do the blood count, you B12, glucose, make sure there's no diabetes. TSH is a test for hormone, for thyroid hormone activity. So that's the usual blood work. It's nothing special. It's not expensive. Then the brain scan, it's done in nearly everyone with memory complaints or looking for word complaints. It's usually a CT scan or computer tomography. We usually don't need an infusion or iodine. MRI is preferred. Magnetic resonance imaging is preferred by neurologists because you see more details of the brain. I'll show you some examples in a minute. And what we look for is strokes, small or big, tumors, very rare, too much water in the brain, hydrocephalus, that's also rare. And more relevant to the workup towards Alzheimer is the size of certain parts of the brain. And the one we more closely look at is called hippocampi. And I'll show you some pictures of that. Next one, Dan. So this is an MRI of the brain. You see the brain cut this way. These are different people. What's in red is the area called the hippocampus. And there's one on the right, one on the left. We just circle one for illustration. And 0 means no atrophy. It looks young and healthy. 1 means it's a little smaller, but it's something you see with everyone with age. It's often asymmetric. Number 2 means it's too small. It's too small at any age. And again, it could be asymmetric. 3 is very small, 4, you barely see it. So this is something a neurologist or a radiologist can look at, in addition to looking for small holes, small strokes, or bigger ones, or other changes in the brain suggestive of vascular changes. You can also look at the whole brain volume. So if you see at number 4, the ventricles in the middle, the black, is big compared to the other pictures. So there's more fluid in that brain because the brain is smaller. So MRI, very useful. CT scan, if it's done well, we give similar kind of information, just less precision. Now, we can also do another test. It's often done in Laval and the Greater Montreal region. It's called a PET scan, positron emission tomography, and we use glucose. Fluorodeoxyglucose is the scan you get when you have cancer, and we scan the whole body looking for hot spots. Here for the brain, we use a special camera, and it's commonly done, this test, for people who are younger than 65 with any kind of progressive decline in memory, language, whatever, or atypical presentation. So as I was saying earlier, if you have progressive aphasia, you will certainly get a glucose scan in Quebec. Because we get a map of the glucose where it's being used in the brain, and that's a good reflection of use of glucose by nerve cells and synapses. So it reflects neurodegeneration. And the map you get, it can indicate this is suggestive of Alzheimer versus frontotemporal dementia versus other conditions. I'll show you an example, the next slide. So you have in red, in the middle, someone who's no complaints, no memory complaints, the MoCA is normal. The red means sugar is being burned, is being used by that individual. And on the right, you see someone with mild dementia, and you see the arrow on the top. There's not a lot of red, so that means there's probably loss of synapses and neurons. And the bottom two arrows, you see also decrease in the amount of sugar being used. So that's an indirect reflection of loss of nerve cells and connections. And this pattern is very suggestive of Alzheimer's disease. Other patterns would suggest a frontotemporal dementia. Other patterns could suggest Lewy body dementia. So it's a very cheap, it's actually a very cheap test to run because we use the isotopes left over from oncology. And it's available in all the hospitals in the Greater Montreal region in Laval. Next, please. Now, sometimes we use a spinal tap because this is a more definitive test. The spinal fluid will give us measures of the proteins that are directly involved with Alzheimer's disease and to some degree other conditions. And it's available in Quebec. We send the spinal fluid outside of Quebec right now because we don't have a lab in Montreal, but it's covered also by Medicare. If we ship the sample to a private lab in the US or to Amsterdam, it's a place where the people from Quebec City send their spinal fluid. It's covered by Medicare. Next slide is what we actually measure in the spinal fluid. So A-beta 42 is a protein that increases in the brain if you have Alzheimer. If it increases in the brain, but there's not a lot of it left to go in the spinal fluid. So it's actually low in Alzheimer. Tau is a protein that leaks out of damaged nerve cells. So it's actually high if you have Alzheimer, but other conditions as well. It's not specific. Like if you have a head injury, if you have a stroke or brain tumor, tau will go up because it's just leaking out of damaged nerve cells. But phosphotau, p-tau, is specific for Alzheimer's disease. And this is why we measure all three proteins in the spinal fluid. And that gives us a signature, a biologic signature of whether you have Alzheimer or not. If it's normal, you don't have Alzheimer, full stop. So we have to think, okay, what else could it be? Next, please. Okay, so we've had 1 or 2 visits at the doctor. We did the medical history. We did the physical exam. You had the scan. Now we say, okay, is there evidence of cognitive decline? We have at least 2 measures using the MoCA or the MMSE. Does it interfere with daily life? So we question you and the family, and maybe we sent a social worker or an OT at home. Is there depression? Could be mixed in there. So we should treat depression first and then reassess. There are other conditions explaining the symptoms. So are there, as I will discuss in a second, hearing impairment, social isolation, chronic pain, other factors at play that we can fix? And are there drug side effects? Oh my God, bring your pills, all of them, because some of them interfere with memory. And it may interfere a little bit with memory. 1 pill, if you take 2 pills, like they do the same, you add up the side effects. And the pharmacists have in Quebec a computer checklist. It's called the cholinergic index. And they can say whether taking this pill in addition to the others will actually be make you at risk of memory impairment. And this is reversible. So we really need to see all your pills, whether it's over the counter or prescribed. Next. Okay, now we're going to go through the differential diagnosis. Is it Alzheimer? So there's a definition that's clinical. So it's dementia. The old criteria were age 40 to 90, which make no sense. Of course, you can have Alzheimer before 40, it's rare. And of course, you can have Alzheimer over age 90. And there's nothing else that can explain the clinical changes. This is the old criteria that we still use clinically, but there's a new one. Next slide. It's called ATN. So expect that within the next year, most clinics in Quebec will be using either a blood test to measure amyloid, tau, and indicators of neurodegeneration from the blood, or increased use of spinal fluid that also give you those measures of amyloid, tau, neurodegeneration. So this is the first cause of dementia that we can actually confirm with the biological test, and this will speed up access to new therapies. Next slide, please. Differential diagnosis, could it be stroke causing the impairment of speech or whatever? It's rare nowadays, but vascular dementia was more common 2 generations ago when blood pressure was not as well measured and treated, and high cholesterol. People were still smoking 2 generations ago. And I just read a report today that over 25 years, there's much, from autopsy studies in the communities, there's much less people with small stroke in their brain. And this is something they did in Ontario before the pandemic. Prevention of stroke will decrease the number of people with dementia. To make a long story short, it was working up to the pandemic. So vascular dementia as a cause of dementia is rare. What we see more commonly over age 85 is a mixture of Alzheimer-like changes and small strokes. So prevention of stroke is a way to prevent dementia as you get older. Next. Dementia with Lewy body is not that rare, and family doctors in Quebec are particularly good at picking it up because for whatever reason, they're good at picking it up. The cue is that there are visual hallucinations very early on. So whether you have difficulty with memory a little bit, or looking for words, or looking for your car, if you also have visual hallucinations, you think there are people in the house and you actually set the table for an extra person, or it's company because you live alone, this is a hallmark of Lewy body, a Parkinson-like condition. And these people often have also restless sleep. When they dream during the REM, rapid eye movement, period of their sleep, they shuffle in bed and they actually can fall out of bed or hit their companion. So this is something that family doctors are good at picking up. And of course, they refer for confirmation and there's specific management for that. Next one is, I think, Parkinson. So if you do have Parkinson's disease, after 10 or 12 years of just motoric changes, just tremor, rigidity, a bit of hesitation walking, there is a slowdown of your memory and thinking. It's not a memory loss, it's just slower to remember. And it could actually interfere with daily life. Then you call it Parkinson dementia. And there may be visual hallucinations, but they are not as early as you have in Lewy body dementia. And next one. So that's in the back of the mind of the doctor who sees you, and he's going to say to you and the family, at this stage where I see you now, whether it's mild cognitive impairment, mild dementia, moderate dementia, the most likely diagnosis is. And we will tell you the truth if you ask. We have to tell the family member that will be legally responsible for you if they do accompany you. The rule is to tell the truth unless there's a risk of catastrophic reaction. So if you see someone who says, if you tell me I have Alzheimer, I'm going to shoot myself, okay, you have to think this through carefully. It's rare in Quebec, but you have to think this through carefully. So it's a stepwise disclosure. There are ways to do that. And then plan ahead. So education, it's a team for our dementia education program at McGill. The diagnosis must be as accurate as possible. We disclose it as much as we can safely, inform the family or designated legal representative if it's not a family member and the person with symptoms, and then use all available resources right from the start, education, etc. Next one, please, Diane. So we need to plan across stages. So as I've tried to illustrate with the phases of disease, we need to plan ahead. So if you see someone in mild stage, you know that in 2 or 3 years, they're going to need extra help. So you have to plan with the person and the family, reach out to the community resources before there's a crisis. That's as simple as I can make it. Don't wait for a crisis to plan and reach out to people who can help you, because there will be an increased need. Can you go back, Dan? You're too fast. So planning is required, and you need to refer along the way to the appropriate resources. Thank you. Diane, please. Next. So help with coexisting conditions. This is something Dr. José Moret will describe much better, because geriatricians are very good at this. It's not something neurologists usually do. But impaired hearing, it's a risk factor for a decline in your abilities, and it can be fixed. And of course, visual impairment. Blood pressure may be too low. If you are over 85 and you take too many blood pressure pills, actually low blood pressure may be harmful. Cardiac arrhythmias, so common now to have atrial fibrillation, putting you at risk of small stroke, so this should be managed. Diabetes, of course, should be managed systematically. By the way, did you know that some diabetic drugs are being tested for Alzheimer now? We'll come back to that later if you're interested. Malnutrition, so especially if you live alone, you may not get enough of certain vitamins. That's not so common in Quebec, but it's more, could be an issue. And pain, this is common. So you may have a chronic pain condition that requires analgesics and sometimes opiates, and that can, of course, interfere with your cognition. All this needs to be managed. Usually it's done by the family doctor and his team, her team. If you see a specialist only, we may miss out on some of these things. So there has to be a partnership between specialty practice and primary care practice. This is something they do very well in Ontario. It's under MINT, M-I-N-T, MINT program, where they have an integrated approach to care for dementia in older people. Next one. Okay, medications. So nothing new as in the past 10 years. But we have good ones. So antidepressants, we got good ones. You may need them for the first 6 to 12 months. Remember the first hump, depression, mood change? Yeah, you may need an antidepressant, low dose as just the minimum effective dose, and then you can stop usually after a year. Medications to improve memory, attention, get back some spontaneity in your daily life. Yeah, this is achieved with donepezil. It used to be called Aricept. Rivastigmine, it's also called Exelon. It's available as a patch. And galantamine, it used to be called Reminil. They're equivalent, more or less, in terms of efficacy. Everybody should try them if you have mild dementia or moderate dementia. You just have to find the right dose, the right medicine. Maybe the patch is better than the pill if you have side effects, etc. There's one medicine called Memantine, which was actually used for other things, and it was found to be effective to some degree in moderate dementia for mild agitation, and it does amplify a little bit the effects of the other medications that work on acetylcholine. And finally, antipsychotics, nobody likes them, but if you have someone who's clearly physically agitated, putting himself at risk, you may need a temporary treatment with a drug like risperidone, low dose, and you try to stop as soon as possible, usually after 3 months. So we juggle with these medicines across the stages as symptoms evolve. The next one, please, Diane. Now, new treatments, you may hear from in the lay press, oh, there's a new drug for Alzheimer. Well, bottom line, they're all doing the same thing. It's lowering the amount of amyloid in the brain. And they do that very well, but it's complicated. You need infusions intravenously every month or twice a month of antibodies that will get into the brain. About 2% of what you inject in the vein gets into the brain, not a lot, but that 2% is sufficient over a year, year and a half, to take away the extra amyloid in the brain. That's been achieved. What's not been demonstrated fully is, does it matter? Does it slow down the disease? And if you wait for impairment or early dementia, there is a small effect, but it's small effect. So maybe you need to add another treatment, such as anti-tau, anti-inflammation, something to increase the glucose metabolism. So we're at the cusp of doing combination studies, and this is something you can be part of if you have Alzheimer or you know someone. There's some sites in the Greater Montreal region where you can participate in such studies. This is not for 90-year-old plus people. This is for 60 to 80-year-old. There's different kinds of Alzheimer causes, and they're very different. If you're 40-year-old and it's familial versus 60 to 80 versus over 90, where amyloid is not so important. So message here, there will be a cure for the foreseeable future, and there will not be one medicine for all. It will be a personalized approach. And within the next 3 years, expect that if you go to the specialized clinics, you will have the spinal tap, some blood tests, and maybe a special scan if needed to see if you have what's your profile, ATN and other proteins build up, neuroinflammation, and then we'll propose a specific drug or other treatment than drugs at this stage of disease for you. It's a bit like cancer now. We're 20 years behind in the personalized medicine approach, but we're getting there. And next, we're nearly done. Non-pharmacologic treatments. So Dr. José Moret perhaps will go into that as well. This is something you do already because you're listening to me. So that's a cognitive training, physical exercise. It's been shown that if you combine both, this is done at EPIC right now. You can join a study. You get a free subscription to EPIC at the same time at the Institut de Cardiologie. So they combine physical exercise, aerobic, non-aerobic, with cognitive training in a group. And then they watch your blood pressure and your other vascular risk factors. And this is being tested prospectively compared to usual care. Socialization, arts, music, these are popular topics. They don't make headlines so much, but there's a whole stream of research right now for non-pharmacologic approaches, especially for people before they have dementia. And even in mild stage of dementia, there may be advantages to these non-pharmacologic approaches. And next, Diane. Yes, so to finish, just to say that if you want to read more about all this, the diagnosis and the management, you can download for free the World Alzheimer Reports 2021 about diagnosis, 2022 about management. It's something that we were involved with at McGill to put together. Just go on ADI, Alzheimer Disease International, ADI.org, and you'll get the full reports. Next one. Just a final word. There you go. So the 2022 one includes a chapter about progressive aphasia. And I know it's something close to the heart of most of you in your association. So Dr. Paolo Vitali wrote a specific section in the World Alzheimer's Report 2022 about progressive aphasia. It's pages 313, 314. And you will see Dr. Vitali in a lecture later this year. Next, please. And I think we have, what do we do at the Center for Aging in partnership with the Department of Education at McGill is we have a variety of tools that you can access. Just go to mcgill.ca/dementia. You have a companion guide if you have early stage of neurodegenerative changes. McGill Cares. So there is an interview taking place at noon today with Dr. Isabelle Gelina, and so on, the World Alzheimer Reports. So you can access these resources, and we'll be glad to work with you. Ready for question period?
Wonderful. Thank you so much, Dr. Gauthier. We'll just monitor the chat and see if anyone has any questions, or if anyone also wants to just raise your hand on Zoom, you can also ask a question that way. It's a great opportunity to speak with Dr. Gauthier and get some information if you have any questions on anything that he presented.
I have a question.
Yes, please go ahead.
Okay, it's concerning how do you call it in English? L'amyloïde.
Yes, amyloid.
Angiopathie amyloïde cérébrale.
Yeah.
That's what my wife has.
Okay.
And we're told it goes towards Alzheimer. Is this true?
So it's yes and no. So the amyloid we talked about is in the brain, all over the brain, if you have Alzheimer. Also, if you get older, most people over age 90 have amyloid in their brain all over, as much as someone with Alzheimer, but not all of them have symptoms. So that's another story. You need more than amyloid to have symptoms. The amyloid congophilic angiopathy that your wife was told she has is the amyloid in the wall of the cerebral vessels, which makes these cerebral vessels more brittle and they could bleed. So possibly your wife had a stroke that was in the back of the brain, and they said, it's suggestive of a congophilic angiopathy. It does not mean necessarily that she has Alzheimer, because that would mean the amyloid would be all over the brain. So, but it could be associated with it. So time will tell.
She has micro bleeding all the time.
Yeah. By the way, the new drugs we talked about for Alzheimer, the amyloid drugs, they could cause those small bleeds, especially if you have congophilic angiopathy to start with. So the new drugs coming to Canada, we're already taking ahead. We need stroke specialists to work with us. So we use them safely, especially in someone who has congophilic angiopathy. So thank you for bringing this up. It's a common thing with age that you have amyloid in your blood vessels. Fortunately, few people actually bleed from that unless they're on blood thinners or unless they're getting those new Alzheimer drugs.
Okay, because she has thrombose essential thrombosis as another sickness.
Okay, so that's
it seems that they're both in war, one against the other.
Okay, so yeah, the essential thrombosis means that she has too much platelets and they're sticky. Well, yeah, indeed.
Okay.
I hope she does okay. But the short answer to your question, which is a very good one, is that no, it's not automatic that she will get Alzheimer's dementia.
Okay, I thank you very much.
Thank you. We do have a question in the chat now. Somebody's wondering about swallowing and choking with aphasia. Do you have any advice on that?
Sorry, say that again.
Someone is worried about their husband having difficulty eating, so lots of swallowing and choking, and they have aphasia.
Okay, so, very good question indeed, because it's a complication, usually late stage of conditions such as Parkinson and Parkinson-like conditions and Alzheimer. If you live through the 8 years, now if you have aphasia due to small strokes, you could also have difficulty swallowing, but it's usually non-progressive. And the short answer to your important question is that occupational therapists and speech therapists have designed protocols to avoid complications from the swallowing difficulties. So please, if you see that occurring in someone, tell the team that you are interacting with, and they will get you on the swallowing exercise. And this is actually done very well at the Institut de Gériatrie de Montréal, the old Queen Mary Veteran Hospital. They have a so-called swallowing clinic, clinique de déglutition. And if this is a serious concern that you have, maybe you can ask your doctor or treatment team to consider a referral to the swallowing clinic of the Institut de Gériatrie de Montréal, where you get in a one day a full workup of all the factors at play in the swallowing difficulties, and it may prevent aspiration pneumonia.
Hey, thank you for that answer. I have a few more questions in the chat, so I'll read the next one. So it's about the evolution of Alzheimer's after an AVC. Are people more prone to Alzheimer's after having an AVC, or does it cause dementia? And can dementia wax and wane over time? And can the person have a period where they're feeling better?
Very good questions. So if there is wax and waning and actual improvement, that's more compatible with stroke only, no Alzheimer in the background. it does happen that someone over age 80 who has already a bit of amyloid and tau in their brain because of age, if they have a stroke, they recover somewhat, but they never quite go back to where they were before. And it seems like now they're declining a little bit. So that's the case of someone who had a bit of Alzheimer in their brain, was silent, and the stroke brought it out. But the stroke does not cause Alzheimer. It's there because of age. I don't know if I'm clear about that. So if you prevent stroke in that person and you use the usual readaptation techniques, that person should be improving or stable, not unlike someone with just Alzheimer's disease alone. I'll tell you a secret. When I was in clinical practice, if I see someone with a memory complaint, speech impairment, and they have small strokes, in a way I was able to reassure them that it looks like it's mostly a stroke risk you have. We can deal with that. I cannot do yet much about the Alzheimer aging process. So it's not a bad thing to have a history of small stroke or to have one found on the CT or MRI. It was a silent stroke, because it means there are risk factors that can be readily modified and may be significant in just slowing or arresting progression, compared to someone who has Alzheimer changes only in their brain and they're young, like 60 to 70. That's not such a good prognosis.
Thank you. Thank you so much. These are great questions. We have a couple more questions in the chat. Someone is asking if they can get a copy of the PowerPoint presentation. So I believe that we are going to share it by email after. So there's no problem. You don't have to take notes. We will share the presentation, and we are recording this as well. So the next question is about hallucinations in late stage Alzheimer's. Does that always mean Lewy bodies?
Good question. So the rule of thumb is if they occur in the first 2 years of the onset of cognitive decline, it's suggestive of Lewy body etiology. But many people have both Alzheimer, amyloid and tau, and Lewy bodies in their brain. So does that mean if someone has visual hallucinations a bit later, they have Lewy body or Alzheimer? Probably they have both. The practical impact, I'll tell you honestly, the visual hallucinations may be benign if they don't cause the person to have false beliefs. I'll be more specific. So if you think someone just comes in and share a meal with you and you're kind of happy about it, don't treat the hallucinations with a tranquilizer, of course. But if the impression there's somebody else, that's your girlfriend, and that leads to pathologic jealousy, and then like a florid psychosis, that's a different story, and we may need to use major tranquilizers.
Did you have a question, Monsieur Cal? Is there a question from someone in the audience there? No?
Yeah. Just a minute. Okay.
Hi, do you hear me?
Yes, thank you.
I noticed at the end you spoke about risperidone, the medication, and that they're going to take them off after a while. Well, my husband is on the risperidone, and I'm wondering, will that do something bad effect if they take them off it?
Very good question, because it's being debated for years. When do you stop these major tranquilizers? The rule of thumb is you try every 3 months to get people off, because the symptom you had that required the treatment may be gone by now. As you saw the hump in the drawing, most of the behaviors associated with Alzheimer-like conditions, they improve with time. So if it was pathologic jealousy, if it was false beliefs, there's a stranger in the house, whatever, it may be gone after 6 months or a year. So the rule of thumb is you try to go off every 3 months. At least you discuss it with the doctor.
Thank you.
Is there another question?
There is a question in the chat. One of the questions you had raised during your presentation, which diabetes drugs are being researched for dementia?
Good. Somebody was listening. Guess what? Metformin is the #1. Metformin may be doing something in the brain, even if you don't have diabetes, that is useful in Alzheimer. Insulin also was tried, but that's more tricky because you have to give it through the nose. And the way they were giving the insulin didn't work the first time, but so they're trying again. And there's a new drug from Novo Nordisk. It's used to, I think, lose weight. I don't know it well because I never prescribed it, but it's also being tested. So metformin is the classic one when we're asked this question. And it doesn't mean you should go on metformin if you're not diabetic. Of course not. But it's being tested as we speak, because there is a component of aging that has to do with how well you manage glucose, how well you burn it, how well you use it. And it's been known actually for a good 50 years that there's something happening in the brain with the glucose metabolism, and that's not related directly to the lack of insulin, for instance. And some people actually use the expression Alzheimer is like type 4 diabetes, imagine. So stay tuned. There may be good news from repurposing old drugs for diabetes or new ones in the next 2 years.
Wow, very interesting. Thank you. I don't see any further questions. Does anyone in the audience have another question they would like to ask?
They can also join us at 1:30 in French.
Exactly. Our next session is at 1:30. Richard, did you have someone? Avez-vous quelqu'un?
Oui, c'est juste notre ami Ian, il va présenter un petit peu l'organisme Agapé pour notre clientèle anglophone. Est-ce OK?
Parfait. Please go ahead.
Hi there, and thank you for inviting me. Thank you, Mr. Dr. Gauthier. Very interesting. So Agape is the only English-speaking organization in Laval. We have multiple services, but our main mission in this context is to partner with patients such as AVC-Aphasie Laval. And our goal is to, keep our population informed of the service offer in Laval and to help adapt it for English speakers. And one of the services for clients that we share with AVC-Aphasie Laval is our senior wellness center. Dr. Gauthier mentioned, non-pharmacological treatment and prevention. Our senior wellness center offers many activities that promote health and well-being with similar conferences on health, leisurely activities, all in English for our English-speaking seniors, 55 plus. So I just wanted to thank you once again for allowing us to share our resources, and thanks again.
Wonderful, thank you. Perhaps we can share that in an email when we share the PowerPoint presentation after. I do have one last question here from Harold Bergman. Did you want to go ahead, Harold?
Yes, I'm 92. My grandfather had aphasia where he could not communicate with anyone. Is there any familial connection?
Okay. Thank you for asking the question, because we're often asked, what about genetic risk? And the short answer is over age 90, genetic risk don't apply, because if you were to have Alzheimer, you would have had it already around age 70, if it was familial. So now you're just getting older and wiser, and obviously you're doing well. If you have other people in your life, it's important for men to have a spouse or a girlfriend or equivalent partner, because living alone is not so healthy. So join up, sign up for whatever you like. Play bridge, get a dog. Then
Thank you very much. Very interesting. Thank you. Thank you very much.
Thank you so much for all your questions. Thank you, Dr. Gauthier and Mr. Carroll for welcoming the McGill Dementia Education Program here as part of your lecture series. Our next lecture takes place on March 29th with Isabelle Jalinet. She's going to talk about driving and neurocognitive disorders. And just in case you didn't know, there is this exact same session is also taking place today in French at 1:30 in the same link. So if ever you know anyone, or if you yourself would like to watch it again in French, please feel free to join us at 1:30. Thank you very much, everyone. Have a great day.